See You Now is a podcast highlighting the innovative and human-centered solutions that nurses are coming up with to solve for today's most challenging healthcare problems. Created in collaboration with Johnson & Johnson and the American Nurses Association, and hosted by nurse economist and health tech specialist, Shauna Butler.
This is See You Now, and I'm Shauna Butler.
I believe that organ donation is someone's final act on earth that's made of grace and generosity. And the more that we can do to make that process easier, better, and more effective, we have to.
The gift of life is so precious. And when I think about the recipients, the ripples of that gift are endless. You know, how many people one person can touch?
2020 has been a rough year. Let's be honest. It's kind of been a wrecking ball to so much of what's important, meaningful, and shapes our lives. And it's called upon innovators in healthcare to respond and to do so rapidly and decisively. This disruption has also meant rethinking what is possible in healthcare. And that rethink extends to every facet of caring for our communities, families, people, and their organs and tissue. In this episode, we meet two bold innovators from organ procurement organizations, or OPOs. Nurse Jenny McBride, the executive director of Our Legacy Organ and Tissue Donor Services in Central Florida, and Nurse Patty Niles, the president and CEO of Southwest Transplant Alliance in Dallas, Texas. Their vast experience gives them a unique perspective on the promising spots for profound innovation in organ donation. They have worked closely with patients and families and understand the human drama of the donation and transplant experience. But they're also able to zoom out to see the big picture and take action where innovations in organ donation and procurement can have a national impact. Organ donation often surrounds the worst day of someone's life, and nurses committed to this work have powerful stories that shaped them and their careers. I opened our conversation with an invitation for Jenny and Patty to share theirs.
My first recollection was the ICU doors flying open, and a young man who had been shot in the head was brought into our ICU, and the trauma surgeon's first instructions to the surgical resident were keep his kidneys open, because he knew at that point in time there was nothing else he could do for the patient, but there was possibly something else they could do for another person. And so that physician just rallied the whole healthcare team to do what was best for the situation. And in that moment, I knew where my career was going. And I have no personal connection to donation, but right then I knew what my next career move was going to be. My name is Jenny McBride. I'm the executive director of Our Legacy Organ and Tissue Donor Services. We serve East Central Florida. I became an ICU nurse and then became an organ procurement coordinator. And I thought that's where my journey was going to end. I thought I would work forever at an organ procurement organization and continue to take call and save lives and serve donor families. And then I got married, and my husband moved us to Washington, D.C. And I eventually went to work for the Division of Transplantation. Spent 10 years in a federal government position helping to oversee the organ transplantation network. It never occurred to me when I went to nursing school that I would end up in a role like that. But I have to say, for any nurse, working in the government for a period of time is an incredible experience. It teaches you a lot about the underpinnings of the healthcare system. And for me to have that experience in transplantation and donation at the federal level has really changed how I look at things. I think what it really did cause me to believe is that change and improvement in our industry is incredibly possible. and that we're the ones that are most in a position to be able to do that if we have the courage and the will to do it.
I'm Patty Niles. I am first and foremost a nurse, and it's so funny to hear Jenny's story. There's so many parallels here. There was one particular weekend, I remember it was Easter weekend, where we had a whiteout in Ohio. And if you've ever been in a whiteout, you can't see 3 feet in front of the car. Massive snowstorms. There was a 20-car pileup, and in the middle of that pack was a family of 4, the mom, dad, and 2 kids in the back seat. One was in a car seat. And the father hit the car in front of them because he couldn't see them. They waited for the impact. Kids were crying. Everyone was okay. So mother got out of her seatbelt and went to the back seat to get the child out of the car seat, and they were hit from behind. So she was severely injured. The son was injured. I was in the intensive care unit working as a nurse, and I was taking care of the son. And the next unit was the mother, who was now brain dead and was going to be an organ donor. And I felt myself walking down to that other unit, wanting to see, hear, experience. And I was overcome with emotion that the family could make such a selfless decision in the middle of their tragedy and feel really good about that decision. To see them so grateful that she could save the lives of others was amazing to me. And I caught the bug. I caught that donation bug. I've been fortunate to grow in this industry. I'm president and CEO of Southwest Transplant Alliance, and we are housed in Texas with our main office in Dallas.
What I think is really interesting in the organ donation space is that it's two-sided. It's a very complex, highly sensitive, time-sensitive orchestration of so many pieces coming together and a range of networks that need to weave their services together. How does this symphony work, the symphony of life?
People in end-stage organ failure have suffered for a long time managing their disease. It's a chronic disease, and it doesn't just involve them, it involves their families. It affects every aspect of their life. By the time you're ready for a transplant, you really don't have any other options to treat your illness. Envision this family going to a hospital that they're probably unfamiliar with. Only about 260 hospitals in the country do organ transplants, and there are 6,000 acute care hospitals. So chances are they're going somewhere that they're unfamiliar with, to people with whom they are unfamiliar. They're meeting this completely new group of people, and they have to hope that at the end of a process where they undergo lab work and x-rays and MRIs, and you're hoping that at the end of all of that, a committee of people whose responsibility it is to decide whether or not you go on the list, you have to hope that they decide in your favor. And that's just the first part. And then the waiting starts, and you live your life and you arrange your every activity to be available, waiting for a phone call.
When we get to that point where we're able to make that call, it's so exciting. We do a lot of things behind the scenes, and I call that the pre-work, the pre-donation, where we're educating communities, maybe some DMVs, DPSs, where people sign up and make that decision to say yes. We're also doing a lot of work in hospitals so they know when to call us, how to call us. So when they make that call, we respond, we go in and do an evaluation, and then we determine when the best time to approach a family is. So we go in and work with that family on their worst day. As I always say, it's someone's worst day, and on Jenny's side, that's their best day. It's like that intersection of grief and gratefulness. It's an amazing intersection. You'd be surprised how many people are working behind the scenes for one transplant. There can be up to 50 people working in laboratories, in transportation, on all sides. It's an amazing journey.
So when you were mentioning that there are all these people, it really is a symphony to make it all come together. Who's involved in that? Who's on that team?
So we have requesters, and those are the people that talk to families. They might be chaplains, they might be social workers, people that you would want talking to you in the moment of a crisis. We have a big laboratory where we have people running blood tests. We're testing for HIV and hepatitis and COVID and all those infectious diseases. The nurses and the clinical staff are coming in to do the assessment on the units, to really manage blood pressure and all the dynamics when brain death occurs. Now our clinical staff, nurses included, are now working on organ preservation. They're trying to make sure that the kidneys are functioning, the livers are okay, is the heart maximizing? How is the heart functioning? How are the lungs doing? Are they too wet? Are they oxygenating enough? So we have to do a lot of kind of almost rehab with some of the heart and lung functions to get them to maximize in their performance. So it's just a shift in care, and it's such a delineation of a line of when that occurs. We also have another lab who's doing the cross matches for the recipients. So all those people are working behind the scenes as well.
So you're marshaling an entire army.
Yes, truly.
Yeah.
So it's recovery, that's the recovery side, and then there's the transplant side. So there is delineation between those two functions and roles because they're very separate.
Transplantation is just such an amazing source of innovation. Can you go through some of the timeline? I mean, some of those incredible breakthroughs. I mean, what has been the progression of organ donation and transplant?
Sometimes I have to kind of pull back and go, look at the progress we've made.
Mm-hmm.
I mean, when I started 30 years ago, we collected information about our donor on a front and back sheet of paper. That was part of the authorization, the history, and all of our work went on 2 pages. Now it's like 60 pages. We collect an enormous amount of history and making sure that the organs are safe. You know, we're diving into a lot of that process to make sure that those organs are going to work. The advancements, finding matches, and looking at some of the advanced medical history that they can pull in to make sure it's the best match for that recipient. The immunosuppressive drugs are amazing. They're so much better. They used to be on steroids, and you know as a nurse what steroids does for a long term. It's not a pretty thing to live on those. So those drugs have increased the reliability and the length of a transplant that can last.
As you think about this symphony of players, there are those who are in the clinical side of this, but there are people who are outside in the community, that are in regulatory, that are in transport, that are probably on preservation. Can you fill in when you think about all of the network that needs to be in place for this gift and donation to take place?
Just the transportation people alone, just to get the organ to the right place at the right time is monumental. And can you imagine being on the recipient side and an organ got lost in transit or it missed the plane? All of those things that can go wrong can be disastrous. So trying to manage all that on top of everything else we're managing is difficult. And then throw in a pandemic when there are less flights available. There is less opportunity to get that organ from point A to point C. So those are things we have to manage that have become more difficult because of the allocation of organs. We're sending them further and we're sending them more often out of our areas. One of the things that we have not done before in previous decades is really worry about the governmental affairs piece of it. Oh my gosh, Jenny could really talk about this. She has her finger on that pulse and manages that so well with her history. But there's been so much gone on in 2020 that is things that we would have never considered before.
Why is the government involved? What are the rules and the regulations and the policies that oversee organ transplant?
The government hasn't always been involved, but in about 1986, there was a not uncommon occurrence in the media where a family would go on television and beg for someone to donate an organ to someone that they loved. Children in need of organ transplants, in particular, were given a lot of media exposure. And at the time, it was felt that it wasn't fair that people who could access the media could actually get an organ when poorer people who were just as in need couldn't. And so that's when Congress chose to pass the National Organ Transplant Act. And the most important thing that act did was to create what's now known as the Organ Procurement and Transplantation Network. And that network, known as the OPTN, is made up of every organ procurement organization in the country and any hospital in the country that is given permission by the OPTN to perform transplants. So you have to qualify to become a transplant hospital, and you have to meet a stringent set of criteria in order to gain the privilege of receiving transplantable organs. One of the most important functions of that network right now is to be able to create the medical urgency criteria for every candidate who comes to the waiting lists, so that it is very transparently known which candidate shows up in the number 1 position for an available organ, who's number 2, and all the way down. And as organ procurement organizations, we are responsible to be faithful to that waiting list when it is generated, so that people can trust that they are treated fairly. And that wasn't always the case. Even after the government created the network, there weren't very good controls. Just because a transplant center indicated that a patient was waiting in the ICU, there was no way to be able to validate if that was really true. And so in the 1990s, it was kind of like the next big leap in the late 1990s, early 2000s, when the government required there to be quality checks on the accuracy of the information. So that was kind of the next big innovation. That, along with the government insisting that organs be allocated not necessarily just based on the geography of where the recipient was as compared to where the donor was, but also the level of illness of the recipient. That wasn't attended to as much as the government felt that it should be. And it was felt that medical urgency and the potential life of a transplanted organ and the life of that transplanted recipient was something that should be considered. So relative scores were developed to determine how sick a patient was. And the scores started for allocating livers. It's gone on to lungs and hearts now. And I think there's a great deal more trust among the community now than ever before. And I think that has a lot to do with the government's role in the process.
One of the things that's been so fascinating is the biomedical advancements and what we are able to make available for donation. What are the advancements that have been made, and how have those advancements been made?
Many of the advancements have been made in the preservation area. There are so many areas with organs on that preservation side where we can put organs on pumps and they can last a little bit longer. But also on the tissue side, there are many more uses than there used to be. They have done a lot of surgeries with bone grafts. They can do a lot of repairs, massive wounds that aren't able to heal. They can use some skin to bridge that healing so that wounds can, especially in the diabetics, that they just don't heal very well. They can use some of that skin that's recovered from an organ donor or tissue donor to do the repair so it will heal faster and have the real closure that it needs.
One of the biggest innovations in skin recovery is the use of skin to aid in reconstruction surgery after a mastectomy. There was a while that skin was just really not being used all that much, and the realization that skin could be used for this purpose has made skin recovery so much more needed now.
I want to be able to give as many gifts as I possibly can. So going from head to toe, what would I be able to offer as a gift?
The vital solid organs, heart, lung, liver, kidney, pancreas, small bowel, and then so many tissues. You can start out in the brain with dura, can be donated, pericardium, heart valves, corneas, veins like the saphenous veins, mammary veins, tendons, ligaments, skin, bone, portions of muscles. What am I forgetting, Patty?
The only I can think of is there's some research ones that are really making big strides in some cancer treatment and such. So we recover prostate tissue for our university here in Texas to help the universities do some research for cancer on that. And that has been a game changer for them. They're sharing that tissue all over the world to really combat prostate cancer.
So the issue of this imbalance where there are so many more people awaiting some type of a donation and so few tissues or organs that are available. How are you managing this mismatch? I think that there has been this idea that we're going to biotechnology our way out of this to increase the supply. But as you're sharing the process, there are so many different pieces that are involved. And just thinking about the policies around that, the technology, the scientific advancements, the preservation, from the standpoint of making more donations available, what are some of the ways that we're not thinking about that?
I think we're actually doing pretty well in terms of situations where people are brain dead, who have some type of insult to the brain. They're on a ventilator, they're in an ICU. And I think in general, a lot of parts of the country are collaborating with doctors and nurses in the critical care setting to make sure as many of those kinds of donors can donate. But there's a second process called donation after circulatory death, where people become donors after being removed from the ventilator. These are cases where it's determined by the healthcare team and the family that additional care is futile, and they don't want their loved ones to be on ventilators. And so a decision is made to remove that person from the ventilator. And if the hospital and the organ procurement organization can collaborate and coordinate in a timely way, the family can be introduced to the organ donor team, and a decision can be made about whether or not that patient can be a donor after they're removed from the ventilator. You know, it's estimated in the US that there are probably only about maybe 10 to 15,000 brain deaths in the US. But it's understood that there are maybe just as many and maybe even more patients who are removed from ventilators in our nation's ICUs who could become donors after their hearts stop. And it's my belief, and I think Patty has some great experience that will document that if the connection between the OPO and the hospital can come at exactly the right time, that the possibility of donation exists if we work together well.
This is hard work to get all of these pieces to come together. What are some of the places that, if we were to think about it differently, if we were to innovate, we could help to address the imbalance?
Well, there are about 108,000 people on the U.S. transplant waiting list. And a good way to think about that is you think about the Rose Bowl in Pasadena, California. There would be a person in every seat in that Rose Bowl in need of an organ transplant. It's a lot of people. And that's only a subset. You know, there are probably millions of people in the US with end-stage organ failure, heart disease, kidney disease, liver disease, who maybe could benefit from an organ. But the exact right circumstances don't exist in their personal situations for them to be put on a waiting list. Being put on a waiting list, it's almost like a whole bunch of factors have to come together at once. You have to have the exact right clinical condition, the exact right social condition, the exact right family support system, the exact right financial situation. All of those things have to be right to get on a list. And the reason the criteria are so stringent is because so few organs are available. And they want to make sure that if someone does receive a transplant, the best use of that organ will be fostered by the patient, by their family, and by their life circumstances.
Being a good steward for a very precious resource.
Yes. I mean, we could almost have 500,000 people on the waiting list if we just let people on who had end-stage organ failure. But it's a much more constrained number because the donation opportunities are so limited.
Interesting question that just came to mind. We focus a lot on the supply side. How are we going to increase the supply? What are we doing to reduce the demand? What's the innovation there to have fewer people need organ transplants?
Well, I think they've seen that with some of the the heart innovations and the different systems and treatments, I think the reduction in people waiting for heart transplants has become apparent because of better treatments before the disease. And I think that's remarkable. I'm always impressed when, we have hearts and try to get them placed for transplant, and there are fewer opportunities. That's a medical win. Yeah. I love that. We had one of our transplant programs in Dallas, a particularly large one, that transplanted their list. I mean, they had nobody else on the list. I was amazed at that. That goes way back to even kidney care and the treatment of high blood pressure and diabetes, all those things that cause kidney disease and failure. I think there's a lot of opportunity there.
So with this scarcity and an algorithm or a prioritization that can change at any moment, you also need to have somebody's status. And if somebody's deteriorated and they're not going to survive the surgery, you're going to be incredibly reliant on these databases. We don't want to see any organ or tissue wasted. So, Jenny, when you say there's a lot we can do in process to maximize the organ availability and to do a better job of organ management, what are we missing? What do we need to do?
One of my favorite things is when I'm watching a medical show on TV, when you are watching a transplant story and all of a sudden some eager physician says, oh my gosh, this patient can be a donor. And he runs out of the patient's room and into the nurse's station and types a few keys into the computer. And he says, oh, there's a match for the heart in Cleveland. That took 5 seconds. And sometimes I wonder, does the public really think that's how it works? And it doesn't. It takes days from the time that a patient is declared brain dead until the time that we are taking that donor to the operating room. But they don't understand that there is a process that we have to engage in for each organ where we rigorously test it and test every aspect of it to make sure that it's healthy enough. And what seems counterintuitive, but is very true, is that when a patient with a head injury is being treated to save their life, the things that are being done to save and preserve the brain are often in direct opposition to what is healthy for the organs that could be transplanted. And what I mean by that is that when you want to save lungs for transplant, we like to see lungs that are very well ventilated and expanded. But when you're trying to save the brain, you don't want to overinflate lungs. You don't want to hyperinflate them. You want to keep them just very minimally ventilated, just to the degree that you need, not to the degree that they can be expanded, because inflating lungs means increasing brain pressure. And they want to avoid that. You also want to make patients as dehydrated as possible to save their brain, but that's not good for the kidneys. It's not good for the heart. So all of these things are happening to save the brain that are hurting the organs. So when we are allowed to begin our process, we have to undo all of those things. And that takes time, and it takes skill, and it takes coordinators, nurse coordinators who are very, very knowledgeable about what happens to someone's body once they become brain dead. Our hemodynamic system, our blood pressure, our heart rate, all of our metabolic processes work differently after we're brain dead. And, I kind of like to say that the nurses are the mini brain stems. They are returning all of that function to the donor that the brain can no longer give. And as organ procurement organizations, and there are 58 of us in the U.S., we are not all equally as good in that process. And I think that's where the big innovation opportunity is how to raise everyone's level of expertise in a profession where, on average, people only last 2 or 3 years. And just when you're starting to get good, you leave because you're burnt out, you're tired. And so how can we use technology to not just make sure that nurses know what to do in the moment when they're managing a donor, but how can we use those databases to help better inform us as to what the best donor management practices are. Right now, mostly we just have our individual experience. How can we take that experience of 58 organ procurement organizations and harness it so that we're all practicing together and that we're learning in the best possible way how we can continue to improve our donor management work?
Patty, I think you've been working an awful lot on thinking about how to better manage notification and alerts, being able to interact with medical records across the board so that, first of all, you can reduce the amount of time, and I would imagine using an AI or something like that, you can actually scan for symptomatology, sentiment analysis to help figure out who's the right person, when is the right time to talk with them.
I look at every opportunity to maximize donation, getting the referrals timely. Everything that I do depends on you as the bedside nurse calling at the right time. That's wrought with all kinds of system failures, and it's a manual process. So that's been a frustration. So it is taking the manual system away from the nurses picking up the phone to call us, and it's creating clinical triggers inside their EHR systems. So when a nurse is charting in real time and charts that they're going to do a brain death test or they're on a ventilator, they have a Glasgow scale of such, or brainstem reflexes of such, that creates an automated referral to us. So that now comes into our donor record system to create a flag for us. So that was our first generation. We piloted this down in Tyler, Texas, in a smaller hospital, and had really great results. But we found it was dependent upon their EMR system, and it was dependent upon those calls coming through, those codes written for whatever electronic health record they had coming to ours. So it was one that we had to create in every single hospital. It was an uplift that has been difficult. So we're on to version 2, and you are one of the first people to hear this, and it's called the Starter System. STA, meaning Southwest Transplant Alliance, that automated referral system that starts that referral process. So we are piloting this at a large health system here in Texas, where once those triggers are met, it will come directly to us. With this, we're creating this health exchange system, health information system that's exchanged directly to us. So their entire medical record will come to our system. Currently, when we have an organ donor, we spend up to 6 to 8 hours of chasing donor medical records. It's crazy, that system. Yeah. So that's a barrier to us. So now we'll be able to do that exchange of getting that direct information to our system, and then we can fire it to our electronic donor record system. What's unfortunate that happens, if I am at hospital A and I have a donor there, and I know that that patient was treated at hospital B for something a month ago, I have to go to that hospital to find out what happened. That's another 6 to 8 hour chase of medical information. So now I can just access that and get that as well. And that will provide safer organs for recipients, because they might have had an infectious disease, they might have had a cancer that was treated elsewhere that we don't know about. So it enables us to gather all that information that has been so laborious, and not just for my OPO, but every OPO across the country. So there's several fixes inside this starter system. The timing of it, making sure it happens, and the remote access to those medical records coming seamlessly to us has the potential to really revolutionize organ donor referrals and get us the information we need when we need it.
Yeah. We are at a very consequential time right now in organ donation history. And I will give you what I'm thinking through the lens of some of the colleagues that I work with. We are all nurses, and we have kind of kept our noses to the grindstone for years now in doing this work. And we're smart enough to know what the solutions are. And what I think is really exciting is that we are now at the point where we can just reach out and start partnering with outside experts to make this industry better, because we know we can't continue the way we are using the old methods, because there are a lot more people that we can save. We are finally finding our voices. We're coming out from behind the transplant surgeons and we are saying, this is what we need. This is what we're going to do. And we're not going to wait for permission from someone else to get it done. And Patty has been a very leading voice on this.
I hear the boldness and I love it. With COVID-19, it's created a whole set of challenges, but it has spurred so much innovation. Has it given you a moment where you could say, we just need to do this differently and we need to do it now, and been able to seize the pandemic and maybe make some of these changes faster than you would have?
I would say for us, you would have thought we had a crystal ball and saw COVID coming, because we have been planning our new facility for about 5 years. We have learned from some of the best, like Diane Brockmeyer in St. Louis, who did the first recovery center in our country. But I am in Texas with a large geography. So I want to walk you through that process, and then I'll explain what I'm talking about. So when I have an organ donor, I'll say right next to Arkansas, there's a little town called Texarkana. So if I have an organ donor in Texarkana, that's 180 miles away. So that's 360 miles round trip. In the course of 2 days, I will send about 8 teams to pick up blood, to talk to families, to do the donor management. And then I'm going to follow up and send 3 chartered airplanes with the heart team, the lung team, and the abdominal team. So I have 3 planes and 2,800 miles of driving. It doesn't make sense. It's inefficient, it's unsafe, and it adds to that burnout Jenny was talking about of our teams. So I created our own recovery center. We call it the Legacy Center. It is comprised of a donor care unit, DCU instead of ICU. It looks very similar to an ICU. We have 6 beds, and then we have a 5-bed operating room. So we have several areas to do the recovery in, 1 for tissue, and then 3 for organ, and then 1 for preservation. We're doing a lot of work with some of our partners in the perfusion area, meaning if there's a heart that is recovered and they want to put it on a pump, we have a place for them to do that. So we have a team that's doing that. That's one of those innovation arms that we've teamed up with a group called Transmedics. We have found when we transfer our donors here, we can actually recover more. Mm-hmm. So especially if we're transferring from a small hospital that doesn't have the technology that we need, we can transfer them in and work with their lungs and optimize their lungs to the point where the lungs can be transplanted. Whereas if we left them in a small hospital, we wouldn't have been able to recover the lungs. We're now working in the perfect environment for COVID, which means that we can now transfer that organ donor from Texarkana down to our recovery center. That's one of those innovations that I applaud St. Louis for seeing this years ago and building this, but we're the first of its kind in this part of the country. In the face of COVID, when hospitals are saying, please, we need this bed, can you move your organ donor? Now we can transfer them and reduce that ICU burden.
But when the pandemic hit, the funny thing for us is my OPO is based in Orlando. And what else is also in Orlando is Disney. And we were absolutely convinced that when the pandemic hit and 1 million people went home from Disney, that organ donation would stop in Central Florida. And the opposite's been true. We have continued at a pace that exceeds what we actually thought we would do for 2020. And I think that's because there are people who are becoming sicker because they won't seek care in a hospital. They're afraid to go into a hospital. And so their strokes and their heart attacks are more significant, and deaths of despair, suicides, and drug overdoses have been much more frequent this year. So I feel that our pandemic experience has been less about what we can't get access to and more about the suffering that we're seeing in Central Florida because of the pandemic. And it has resulted in more organ donations. We actually may not know yet, and we may not know for a little while, what the impact of COVID has been on the transplant waiting list, but we already do know that people who have been dying of COVID and had no other option have received lung transplants. I know of one here in Orlando where it's happened. Patty may know of others as well, but I think that the incidence of end-stage lung failure in particular, because of COVID, is going to become a new diagnosis that we have been completely unfamiliar with until now.
So one of the things that the pandemic has done is it's pointed its finger at all of the inequities. What do you know about organ donation and health equity?
What we do know is that the rate of donation among peoples of color is lower than it is among people who are white. And we think that the main reason for that is the relationship between communities of color and healthcare institutions. So in order for people to feel comfortable saying yes to donation, they have to believe that the care that they received in that ICU was thorough and given with a great deal of compassion, and that the patient and the family were at the center of the process. And if there is distrust when families come to the hospital, if that trusting relationship isn't developed, we are not going to be able to ask them to look beyond themselves to give the gift of life. And so that's an important challenge for all OPOs around the country, is how can we build those relationships sooner? How can we go into the communities of color in our service areas and ask them to begin to hear us and to get the privilege of talking to them about the need for transplantation in communities of color, because it is significant. African Americans who have hypertension and diabetes often wind up on dialysis and in need of kidney transplants. And we need to make it possible that no matter what your race is, that you are able to receive an organ transplant. And right now in the US, we're not there yet.
You touched on a really interesting point, because so much of the innovation lens or the attention is focused on a technology, a database, a 3D printer, a drone. But there's a lot of innovation that needs to be done in wading into these really sensitive conversations. What do we need to do to innovate on the human level? You know, you mentioned developing trust and rapport. How do we do that?
I think the biggest innovation is actually being talked a little bit about right now. Patty and I are both members of committees that serve the Organ Procurement and Transplantation Network. And one of the things they're starting to talk about right now is how to get their committees more reflective of the diversity in our country.
Representation matters?
Yes. We have a very white healthcare workforce in this country, and it's probably even more exacerbated in organ donation and transplantation. The people in leadership positions in our network are all white, often white men. So we have to recruit and promote people of color in our profession, and that's really where it starts.
Talking about the human side of innovation and how do we think about what do we need to do to develop long-lasting relationships with people who have been family members of donors. I've participated in 1 or 2 honor walks. When I first started my career, we weren't doing that. And I think back to those moments in time, what a missed opportunity that was. I was wondering what your thoughts are about the rituals of care and how that has a long-lasting impact on the relationship and people feeling really good about the donation that they've made.
Our goal with families is to make sure that they feel good about this decision today, a week from now, a month from now, and a year from now, because there will be peaks and valleys, and we don't want to force them into something that they don't want, but we also, this is hugely important, we also don't want them to miss this opportunity, because families have a lot of solace and comfort after the fact. There are many opportunities where families feel so good about that decision they made. And I don't know if you've ever heard of our moment of silences that we have in the operating room, but those are also impactful.
Yeah, I'd like to hear that. What is one?
Those are a time before the operation starts. So before any incisions are made, everybody stops what they're doing in the operating room. We usually ask the family if they want music played, if they want a poem read, if they want scripture read, if there's anything special they want. So in that moment, we do what the family asks us to do. And everyone just kind of takes a moment to realize the human being in front of us, that person in front of us who has graciously decided, maybe on their own, to be an organ donor. It's a beautiful moment. We had a sculpture made in our new facility, and we've called it a moment of silence because it's so impactful. And it's, you kind of have to pause afterward and go, okay, it's time to go to work. But in that moment, everyone is thinking about that person. It actually means as much to the hospital staff members as it does the donor families.
Yeah, absolutely. And the honor walk ritual has been so incredible as well. And they started as flag raisings outside of hospitals. And we would invite families to come back to hospitals after their loved one died and raise a Donate Life flag in honor of their loved one. And that went on for a while. And I don't know who came up with the first honor walk, but God bless them. See them lining the hallways is just the most incredible emotional thing. My staff cry when it's happening.
I can't even imagine doing it myself, but walking the donor in the bed down to the operating room where the final goodbyes are said. It's a moment that the family is willingly sharing with all the hospital folks. I mean, that's a private moment. That's a painful, painful moment. And for them to share it so openly speaks to their own spirits. So I'm always awestruck.
We had a family come to Orlando from Boston. They came to Disney World. And while they were on Interstate 4 here, they were rear-ended by a truck driver, and all 4 family members were killed. They died in different hospitals, but the final death was resulting in an organ donation. And so our entire team that was in the office that day went to the pediatric hospital, and we lined the hallways, and we participated because there were no parents. There was no one from the family who could be there. So we all went to be there for them. And we lined the hallways from the ICU all the way to the operating room elevator so that there would be somebody with that little boy when he went to the OR with his Superman cape, because that was important to him. He loved superheroes. So he had a Superman cape over his bed that the staff gifted him with. And we all took him to the operating room. It was really one of the most emotional experiences ever.
I think it shows so much respect to that donor. We even have hospital administrators who come out and join that.
Well, that's what I've noticed with all of the honor walks. It's not just a group of people in scrubs. You will see people who have come up from the laboratory, who've come up from the kitchen, from security. There are people who are visiting. There are other family members. And it is just a moment of sheer humanity. We don't necessarily think of ritual as innovation, but these are things that are evolving over time where we're trying to find meaning and purpose and celebration. So, Jenny, when you speak, your voice just says a bold innovator. And when you are advocating for somebody on a wait list who's dependent, when you're advocating for somebody who's made a request that this is what they would like, that they would like to make this donation, it feels like you have to be bold and you have to think differently in order to respect both the request that was made and the need that is there.
I believe that organ donation is someone's final act on earth that's made of grace and generosity. And the more that we can do to make that process easier, better, and more effective, we have to. And I think what's really true is we need partners to innovate with us. We don't have everything under our roof. And so we really welcome the opportunity to talk with people who are smart and have solutions, because we can't do it without people who care about it.
The gift of life is so precious. And when I think about the recipients, those who get that gift, it's obviously for them, but the ripples of that gift are endless. How many people one person can touch? We have a girl in our community who got a liver transplant who's doing such good things in our community. When I think about her being out of it because she didn't get her transplant, I just think about that emptiness that she feels and the work that she's done that wouldn't have happened.
Around the holidays, you're always thinking about making sure the chairs are full around the table. And, this year they certainly won't be. But as Patty said, the fact that we have families who are willing to look beyond that empty chair and make sure that another family doesn't have an empty chair, that's what the holidays mean. And the holidays are a tough time for our families, but as Patty said earlier, they all know that there's a chair filled somewhere because of what they did and what their loved one did. And more importantly, that their loved one is remembered. That's all they care about. They don't want thanks. They don't want attention. They just want to make sure their loved one is remembered somewhere on this earth.
Nurse Jenny McBride is the Executive Director of Our Legacy Organ and Tissue Donation Services in Central Florida. She brings to that role experience as a public health analyst at the U.S. Department of Health and Human Services as part of the Division of Transplantation, where she developed a deep appreciation for the ways government and policy can foster innovation in organ transplantation. Nurse and innovator Patty Niles is the president and CEO of Southwest Transplant Alliance in Dallas, Texas. She has 30 years of experience in organ donation and transplant care. She is credited with turning Southwest Transplant Alliance into one of the most successful organ recovery organizations in the country. Together, they are on a mission to make more organs and tissue available for more people. Organ transplantation has a thrilling history of innovation dating back to 1954, when the kidney was the first human organ to be successfully transplanted. Liver and heart and pancreas transplants were successfully performed by the late 1960s, while lung and intestinal organ transplant procedures started in the 1980s. Innovation stories that make the headlines on organ transplants tend to feature the biomedical and technology advancements, 3D printing of tissue and organs, using drones to deliver them. But there are lesser-known parts of this innovation story that are hidden deep in the complex details of the recovery and transplant orchestration. Details where innovation can increase the number of donations through innovating on the donor management and tissue preservation side. In most innovation endeavors, it's hard to understand the important things from a distance. You have to get close, get steeped in the details. Creating new approaches to organ recovery, to preservation, and transplantation happens because the researchers and scientists and clinicians understand the details of this high complexity tissue exchange with precision and clarity. Innovation emerges when people are able to investigate right down to the cellular level, to examine with such insight and knowledge that they can innovate, that they can bring something new and revolutionary to life. That's how we make progress. In the loss that creates the gift of an organ donation, there's a legacy that's left. One act, as Jenny describes, of grace and generosity can touch so many others. A wound will heal, a heart will beat stronger, lungs will breathe deep and easier, sight will be restored. It's far more than an innovation. It's a miracle. From all of us at See You Now, I'm Shauna Butler. Thanks for listening.
Subscribe to See You Now wherever you get podcasts, and we'd so appreciate it if you share the show with your friends. It really helps us out. Johnson & Johnson is proud to power up nurse-led innovation that is transforming health outcomes through skill building, leadership development, and more. The American Nurses Association ignites and celebrates nurse-led innovation to redefine quality nursing and advance health care for all. Learn more at seeyounowpodcast.com.